Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach. And today we'll be reviewing a Step 2 CK question in OB. So let's start by reading the stem. A 26-year-old primigravid woman at 34 weeks gestation presents to the emergency department with 6 hours of worsening, severe right flank pain, nausea, vomiting, malaise, and chills. She reports good fetal movement and mild intermittent uterine contractions. She denies vaginal bleeding or leakage of fluid. Temperature is 38.2 Celsius, heart rate is 118, respiratory rate is 20, and blood pressure is 94/65. On examination, she has diffuse abdominal tenderness, worse in the right mid-abdomen without rebound, guarding, or costovertebral angle tenderness. Pelvic examination reveals a closed cervix. Laboratory studies reveal a serum leukocyte count of 17,400 with a left shift. Microscopic examination of a clean catch urine specimen shows 4 to 5 leukocytes with positive leukocyte esterase and no nitrites or bacteria. Fetal heart tracing is reactive with moderate variability and a rate of 165 per minute. Which of the following is the most likely diagnosis? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's approach this question together. So the first step is going to be to read the very last sentence of the stem, so to read the question itself. Which of the following is the most likely diagnosis? So this is going to be a question about diagnosis. And then we take a quick glance at the answer choices. And we see that they all involve some form of infection. And so this is going to be a clue. We know which category of diagnoses we're going to be in. We're in the category of infections. And so as we're reading the stem, we should pay specific attention to what the potential source of the infection is, or what the underlying infection that this question is trying to get at is. So let's read from the top and let's highlight the key elements. A 26-year-old primigravid woman at 34 weeks gestation presents to the emergency department with 6 hours of worsening severe right flank pain, nausea, vomiting, malaise, and chills. So here I underlined severe right flank pain as well as vomiting. Nausea goes along with vomiting. Malaise and chills are very non-specific. So although it wouldn't be wrong to highlight those, I try to really focus on highlighting the key elements that are more specific, and these are more non-specific findings. She reports good fetal movement and mild intermittent uterine contractions. She denies vaginal bleeding or leakage of fluid. And that's important, we'll see why. Temperature is 38.2 Celsius. Heart rate is 118. Respiratory rate is 20, and blood pressure is 94/65. I also recommend highlighting the abnormal vital signs. So here she has a fever, she's tachycardic, she's a little tachypnic, and the blood pressure is still within our normal range, but it's on the lower end of normal. On examination, she has diffuse abdominal tenderness, worse in the right mid-abdomen, without rebound, guarding, or costovertebral angle tenderness. So I think it's really important to highlight not just the abnormal exam findings, but also to pay close attention to the pertinent negatives, because often we'll be able to narrow down the answer choices to maybe 2 or 3, and then we were really going to rely on the pertinent negatives in the question stem to help rule out some incorrect answer choices. So as you're reading, pay attention and highlight the very specific pertinent positive findings in the history and exam, but also pay close attention to pertinent negatives, because those will really help you eliminate incorrects. Pelvic examination reveals a closed cervix. Laboratory studies reveal a serum leukocyte count of 17,400 with a left shift, and microscopic examination of a clean catch urine specimen shows 4 to 5 leukocytes with positive leukocyte esterase and no nitrites or bacteria. I also recommend highlighting abnormal lab findings. And if you are checking those lab findings with the reference range, try to just check them once and then highlight the abnormal lab finding, and then try not to refer to those reference ranges again, because that will take a lot of time. Fetal heart tracing is reactive with moderate variability and a rate of 165 per minute. So before we go on to the answer choices, I think let's do a few things. First, I think we should interpret these lab findings. So when you have lab findings like this, often they'll just list a lot of numbers, or a long list of labs, and I think it's helpful to try to provide some sort of synthesis or interpretation of those findings. So let's do that first. So we're told there's a leukocytosis with a left shift. So that certainly doesn't require much interpretation, but is consistent with some form of underlying infection, especially with the left shift here. So elevated white blood cell count with a left shift. And then the next thing to interpret is the UA findings. And so this UA has a small number of leukocytes and positive leukocyte esterase, but no nitrites or bacteria. So remember that leukocyte esterase could be positive anytime there are white blood cells in the urine. It just is a marker that there are white blood cells in the urine. So it's not specific to a urinary tract infection, it just is there whenever there are white cells in the urine. So sometimes there can be white cells in the urine if there is any type of inflammation. It could be if there's infection. Sometimes it can be just a few white blood cells that are there from the way that the urine is, the specimen is collected. And sometimes it's actually normal to just have a few leukocytes in the urine. So whenever you see positive leukocyte esterase, don't instantly jump to infection because it could be other things as well. And you want to look at the other findings here as the presence of nitrites or bacteria. So nitrites are more specific to a urinary tract infection. So nitrites are more specific to the presence of bacteria in the urine because these are made by bacteria. Or if you're told specifically that there's bacteriuria or that the urine culture is growing a specific organism that is known to be a uropathogen, those are all more specific to the presence of a urinary tract infection. But here, we just have a few leukocytes and we have no nitrites or bacteria. So this UA is actually not consistent with a urinary tract infection. It just shows that there's pyuria in the urine, right? White blood cells in the urine, but that can be seen in a few different scenarios. All right, so we do have pyuria. And remember that in urinary tract infections, typically the white blood cell count is higher than 5, and sometimes it's even closer to 10 or more. And so here we have a small number of whites, and this is meant to be a bit of a distractor for you because in fact it can be normal in pregnancy and in certain conditions in pregnancy to have a small number of white blood cells. So we'll keep this here because it could be helpful, but it could also just be there as a distractor. Then we look at the fetal heart tracing, and I think it's also important to interpret the fetal heart tracing. When you read that it's reactive with moderate variability, those are both normal findings. The rate is on the higher side, so there's maybe very borderline fetal tachycardia, but overall, the variability is moderate is a normal amount of variability. The fact that it's reactive, that means there are accelerations, that's normal. They don't mention any decelerations. So just besides just a little bit of fetal tachycardia, this is an overall pretty normal fetal heart tracing. So that's reassuring. And so now when we move on to the answer choices, let's take a moment to pull apart some of the key findings because this is a long stem and there's a lot here. And there are a lot of things that are meant to distract you from what's actually going on. So to summarize what's going on in this woman, we have a woman at 34 weeks gestation with acute onset abdominal pain that seems to localize to the right flank on presentation, and on exam also is worse in the right mid-abdomen. So definitely worse on the right side. And has some fever, tachycardia, which are consistent with the fact that she has an infection here. So fever, tachy. And then we really have to pay attention to some of the more nuanced findings here. So she not only has abdominal pain and flank pain, she also has vomiting, nausea. We're also told that she has a lot of pertinent negatives here, right? So there's been no leakage of fluid. She has no rebound or guarding, and she has no costovertebral angle tenderness. So this is going to help us eliminate some of these other answer choices. And we're also told that she has a closed cervix. So let's look at these answer choices and try to work through and eliminate a few of these that are wrong and kind of explain why, because this presentation is relatively nonspecific and could be consistent with a lot of these answer choices that we have here. So let's work through them and see why these are wrong. So cholecystitis. So cholecystitis certainly could present with acute onset abdominal pain on the right side, as well as fever and leukocytosis. So that could be consistent. So which features are not consistent with cholecystitis? So we would expect more right upper quadrant pain, not kind of mid-abdomen flank. We would also expect it would be more likely that there would be some amount of rebound or guarding, and potentially there would be a Murphy's sign. We're not told about any of those findings. And the pain doesn't seem to radiate to the back or the right shoulder, or the right scapula. So if there was nothing else here that fit, I think this certainly could be a possibility, but there's definitely a better answer. And in general, cholecystitis is relatively uncommon in pregnancy. And without any of those other findings, it's not enough to say that this is cholecystitis. So we would expect those other findings that I mentioned. So we can eliminate that one. Chorioamnionitis. So this typically presents in women who have ruptured their membranes, where there's an infection that has ascended into the amniotic fluid and causes an infection of the amniotic fluid. And that typically presents with maternal fever, tachycardia, uterine tenderness, vaginal discharge that is purulent or foul smelling, or amniotic fluid that is purulent or foul smelling. And there's no mention here of leakage of fluid or rupture of membranes. And so with a closed cervix and no leakage or rupture of membranes, chorioamnionitis is not consistent with this presentation. Next, we have pelvic inflammatory disease. So again, this could potentially be consistent with this presentation of a fever, tachycardia, abdominal pain, leukocytosis, but pelvic inflammatory disease is actually really uncommon in pregnancy. Now, it can happen in the first trimester before the cervix has closed and there's kind of a blockage preventing bacteria to ascend into the GU tract. But so it could occur in the first 12 weeks of pregnancy, but it's relatively uncommon. And at 34 weeks, it just would not be likely. We're also told that the cervix is closed. So for there to be pelvic inflammatory disease, there needs to be an opening for the bacteria to ascend into the uterus and the fallopian tubes, et cetera. And so in this case, it's just not likely at all at 34 weeks, especially with a closed cervix. Now, if this was someone presenting at 9 or 10 weeks, it would be higher on the differential, but at 34 weeks, it's not possible. And then we're left with pyelonephritis, appendicitis, and hepatitis. So pyelonephritis and appendicitis, I would say, are my top two on my differential for this presentation in a 34-week pregnant woman with this presentation. Hepatitis, I would say that although this would be more typically right upper quadrant pain, there's no risk factors here for hepatitis. We're not told about any travel or any new foods that she's eaten. There's nothing about the liver enzymes. And so there's just not enough here. Similar to cholecystitis, there's not enough in terms of other findings in the history or on lab findings, or even specifically right upper quadrant pain that would clue us into hepatitis. So without more information, there's definitely a better answer here. And so then we're left with pyelonephritis and appendicitis. And this is a quintessential OB question where you're asked to differentiate between these two in a pregnant woman in mid to late gestation. And so this is truly a classic step 2 CK question. And so let's spend a little bit of time exploring which one it is and why. And so in this case, the presentation could be consistent with pyelonephritis. There are a few features that are actually working against this. So one is the fact that there's no costovertebral angle tenderness, which we would expect in pyelonephritis. Another is that the urine, as we mentioned, the urine here was meant to be a red herring because there are a small number of leukocytes and positive leukesterase. And so if you saw that, you might instantly be thinking, oh, this is going to be a UTI, this must be pyelo. But then they go on to say there's no nitrites or bacteria. So this is testing your knowledge of your interpretation of a urinalysis. And without any nitrites and without the presence of bacteria in the urine, this is not consistent with a urinary tract infection. Everything else, including the flank pain, the fever, tachycardia, the leukocytosis, the nausea, vomiting, malaise, those are all consistent with pyelo. And so this presentation here could be either appendicitis or pyelonephritis. So you're really going to have to look for the CVA tenderness and the bacteriuria on the urine specimen. And so this presentation here is, the correct answer here is E, appendicitis. Now, this is the quintessential step GCK question because the presentation of appendicitis in pregnancy is a little bit different from the presentation in non-pregnant patients. So let's take a moment to review the presentation of appendicitis in pregnancy because it's very commonly tested. And I think it's helpful to think through what these different possibilities are because you might get the exact same question, but one small detail is different. And in that case, it might be pyelo or it might be cholecystitis. Or it might be chorioamnionitis. So I think it's important to understand this question and why it's appendicitis, but also understand what would have made it correct if it was one of these other answer choices, one of these other diagnoses, what would have made you clued you in that it was those diagnoses and not appendicitis. So when I explain those incorrect answer choices, make sure you can understand why those were incorrect and what would make a different scenario correct, what details would clue you in that it was those diagnoses. So let's review appendicitis in pregnancy. So typically, this is going to present with acute onset of abdominal pain followed by anorexia, nausea, vomiting, and fever. So far, this is consistent with the more traditional presentation of appendicitis. And it's still more common to have right lower quadrant pain and tenderness at McBurney's point on exam. This is still the most common presentation, but of course on the boards, they like to test the more atypical presentation. And so you have to keep a really high index of suspicion for appendicitis in pregnancy, especially in these boards questions where they're going to be testing your understanding of this atypical presentation. So why is it atypical? Well, the reason is that the pain can be more in the middle or even in the upper quadrants on the right side in pregnancy. And that's because later in mid to late gestation, the uterus actually shifts the appendix up and out towards the flank. So this could present with right upper quadrant pain, it could present with right flank pain as it did in this patient, or it could be right lower quadrant pain. But keep appendicitis on your differential in a pregnant woman presenting with abdominal pain on the right side, no matter where it is, because of this atypical presentation. And you also are less likely to get McBurney's point tenderness. And again, that's because of the way the uterus displaces the appendix in the abdomen. It's not necessarily going to be in contact with the same structures. And so the pain, it can be localized to different places in the abdomen because of the uterus shifting it in the abdomen. You might also have other GI or GU symptoms. So for example, diarrhea or heartburn or even dysuria, depending on where that appendix ends up being located once it's displaced by the enlarging uterus. And finally, rebound and guarding are less likely in pregnancy than they are in non-pregnant patients. So if you don't see rebound tenderness or guarding, don't be fooled, it could still be appendicitis. And finally, you might see some hematuria or pyuria on microscopic examination of the urine. And that's because the inflamed appendix can come close to the bladder or ureter. And when that inflammation comes close to the ureter, for example, you can have a small number of white blood cells that goes into the urine. And so you could have a small number of red blood cells or white blood cells on your urine. And so you really want to look for those other signs of infection that are more specific to infection, like nitrites and bacteria. If you see those, it's not appendicitis, it's pyelonephritis. But if you only see pyuria and leukesterase, but no nitrites and no bacteria, then you could be thinking that this is appendicitis, and that would not be inconsistent with appendicitis. So careful, this is a really tricky point here. And you can even have some mild pyuria and appendicitis even in non-pregnant patients. So this is a learning point that's valid for appendicitis in all patients. And you would also see a leukocytosis with a left shift, but this would also be consistent with pyelonephritis. So that is not necessarily a specific feature. And it is actually normal to have a mild leukocytosis in pregnancy. And so if there are no other signs concerning for infection and you just see a mild leukocytosis, that doesn't necessarily signify infection. You could have some white blood cell elevation in pregnancy, and it would be mild. It wouldn't be very, very high, like 17, 18, 19,000, but you might see a mild leukocytosis. So without other signs of infection, this by itself is not specific to infection. And this is specifically in pregnant patients. In terms of diagnosis, if the presentation is not clear for appendicitis and you get a question about what is the next best step, the preferred imaging modality to evaluate for appendicitis in pregnancy is a graded compression ultrasound. So if you get a question about what is the next best step, and this is one of the answer choices, and you're concerned about appendicitis, but it's not a slam dunk, this would be the preferred modality to make the diagnosis. And as we've talked about at length already, keep pyelonephritis, chorioamnionitis. You could also consider cholecystitis on your differential, although cholecystitis is very uncommon in pregnancy, although it still could present. And a pyelo is definitely going to be the number one diagnosis that this is compared to on these questions. So keep in mind those specific features that we discussed that can clue you in to whether this is appendicitis or pyelonephritis. And so again, review this question in detail. This is almost guaranteed to show up on your OB shelf as well as on your Step 2 CK examination. So thanks so much for listening, and that wraps up our question of the week.